Okay, good morning once again. Let's start the topic for today, that is headache, one of the important topic or condition or symptom, whatever you want to say in neurology. Now let's start the discussion. Headache is one of the commonest symptom of neurological disorder. There are so many conditions which result in headache. Sometimes the headache is associated with serious underlying disease. One of the important conditions which immediately comes in our mind is subarachnoid hemorrhage. In that situation, headache is very, very severe. Another may be brain tumor, isn't it? Another may be space occupying lesion because of anything else, which can also result in severe type of headache. Now, headaches are grossly divided into two types, primary and secondary headache. Now, let's discuss about them. The different types of acute primary headache disorders are migraine with or without aura, tension type headache, and cluster type of headache. So these three are very common primary headache. So if this question is asked, can you classify primary headache? You take the name of these three conditions: migraine with or without aura, tension headache, and cluster headache. In this class, we'll talk about them in detail. Now, aura means warning symptom or sign. Before headache occurs, the person can feel, yes, I am going to develop headache in few minutes time. So some features would be there, like flashes of the light, some noise maybe, okay, some tinnitus, like sound inside the ear, some tingling and numbness sensation anywhere in the body, maybe some it looks like abdominal pain, so something like that. Those are warning signs or symptom, and these are called aura. The less common type of primary headache are paroxysmal hemicrania. This is a one-sided headache. Hemicrania means one half of the cranial cavity or skull. It's a severe type of headache, and it's a stabbing type of pain there. Sometimes the pain may be on the one side of the face, okay, or behind the eyeball. Idiopathic stabbing headache is another type. Cold stimulus headache is because of exposure to the cold, especially in winter season. Benign cough headache and benign exertional headache. Exertion means exercise, too much, okay. Straining or exercise can also result in headache. So these all are acute primary type of headache. These less commons are, you can easily forget about them. These are not important from the exam point of view or in the Viva exam, but migraine, tension headache, and cluster headache are absolutely important to know. Let's move on. Now, what are the secondary headache disorders? Headache can be there because of trauma. So this is post-traumatic headache. It's a very common condition. Headache may be there. It is associated with vascular disorder now, like subarachnoid hemorrhage. I just now told you one of the most severe condition which result in the worst headache in that person's life. Acute ischemic cerebrovascular disorder. Now, this is CVA or stroke, and this is a ischemic type of stroke. The person will complain of headache. Unruptured vascular malformation. Vascular malformation, also known as AV malformation or arteriovenous malformation. Till now, it is not ruptured. If it is ruptured, it will lead to severe headache than this. Arteritis or giant cell arteritis or temporal arteritis is an important cause of headache. Arterial hypertension itself or high blood pressure can itself lead to headache. This headache due to high blood pressure is mainly in the posterior, okay, part of the cranial cavity. Occipital type of headache is more common in high blood pressure. Now, there are certain headache which are associated with non-vascular intracranial disorder, and these are benign intracranial hypertension or pseudotumor cerebri. So please pay attention here. pseudotumor cerebri means there is raised intracranial pressure, but that is not caused by brain tumor. Okay, tumor like condition that is causing raised intracranial pressure, but it is not really caused by tumor. That's why the term pseudotumor cerebri. This is also known as idiopathic intracranial hypertension. We really do not know the cause. There are certain risk factors though, and some of the risk factors are, so let me highlight a little bit about this. Okay, please pay attention here. Drugs like tetracycline, tetracycline, vitamin A overdose. If we give too much vitamin A in the patient, that can also lead to pseudotumor cerebri. Obesity is an important cause, a risk factor I should say, which is associated with pseudotumor cerebri. Sometimes even the pregnancy, okay, sometimes the pregnant lady can also develop pseudotumor cerebri. So pregnancy, see here. Okay, so these are some of the risk factor of pseudotumor cerebri: tetracycline, vitamin A overdose, obesity, and pregnancy. Now, what can happen to the patient in this type of condition? The patient will have headache. The patient will have visual problem like blurring of the vision or double vision, also known as diplopia. Okay, and patient may have some neurological disorder. The diagnosis is cerebrospinal fluid pressure. This is known as CSF pressure is increased in this condition. Eye examination is very necessary to find out papilledema. Papilledema is quite common in pseudotumor cerebri. That's how we suspect it actually. And confirmation is done by measuring the CSF pressure. And can you guess what is the treatment of this pseudotumor cerebri now? Anyone? What is the treatment?
Sir, we
Decrease
can drain the CSF. We can drain the CSF.
decrease the intracranial pressure by giving some diuretics or some other process like ventriculoperitoneal shunt, etc.
Okay, good, very good, good answer. Both of those answers are absolutely correct. I can agree with you. One, you drain the CSF. A slight amount of CSF is drained, so the pressure will be decreased. Another one, sometimes a shunt therapy can also be done, and some of the drugs which decrease the intracranial pressure can also be used, like mannitol and dexamethasone. Okay, so this is pseudotumor cerebri. Important question from the exam point of view. Others are intracranial infection like meningitis, encephalitis, brain abscess, cerebral malaria. These are called intracranial infection. They can easily lead to headache. And some other, after lumbar puncture also, the person can complain of headache for the few days. This is because of the decreased pressure in subarachnoid space. But nothing to worry. Within few days, the person will be all right. Okay, so let's move further. Now, some other causes of secondary headache disorders are headache associated with substance use or withdrawal. Substance use or withdrawal. Some illicit drug like cocaine, for example. Okay, please mute yourself. Illicit drug like cocaine. These are important ones. Sometimes if a person was drinking alcohol, okay, and now he's like stop drinking alcohol, for example, the person will have withdrawal effect. During that time also severe headache would be there. Another cause would be any type of viral infection or bacterial infection in the body can have headache. We all have experienced that. If I suffer from flu or influenza, I will have headache. Even severe type of common cold is associated with headache. Typhoid fever is associated with headache. Malaria is associated with headache. So any type of febrile illness caused by viruses or bacteria or any other pathogen is associated with headache. Some other causes would be metabolic disorder like hypoxia, hypercapnia. Hypercapnia means excessive level of carbon dioxide in the blood. Mixed hypoxia as well as hypercapnia. Hypoglycemia after doing dialysis therapy, and other metabolic abnormality which are not listed here like renal disorders or liver disorders. These also can be associated with headache. So headache is a very common symptom. It is not only related with the neurological problem, it is associated with so many other as well. Now, last but not the least, you should think about this, some referred pain, okay, from the nearby area, like disorders of the cranial bone, neck, eyes, ears, nose and paranasal sinuses, even teeth disorders. Okay, if we are having any problem there, any pathology there, then we can have headache or facial pain. So we have to think about those as well. So this is these are some of the causes of headache. Now, as a clinician, okay, or as a medical student, you should take a good history of headache. You should try to find out, okay, what is the cause of headache, how severe is the headache, where is the pain, is the patient taking any medicines or not. So different type of questions should be asked. And let me tell you one thing, pain anywhere in the body, the questions are still the same. This is pain in the head or in the face, okay? So questions are still the same. You should never forget that principle. Ask about where exactly is the headache, how bad or severe is the headache, okay? What are the aggravating and relieving factor? What is the relation with food? Are you taking any medicine? So similar type of question. Now let's pay attention here. Is this your first or worst headache? You should ask question like that. How bad is your pain on a scale of 1 to 10? This is a very good way of asking how bad is the pain. If the patient say, okay, if the patient say, doctor, I have a pain of 2 to 3 in the scale of 10, that means it is not very severe. But if the patient say, I think I am having 7 to 8 or even 8 to 9, grade of pain on the scale of 10, that means pain is very severe. So this is a good way, okay, of knowing the severity. What symptom do you have before the headache starts? What symptom do you have during the headache? And what symptoms do you have right now? Very important question. These are called associated problem with headache. Sometimes patient is having fever with headache. Sometimes, okay, patient is having vomiting with headache. Sometimes patient is having blurring of vision or double vision with headache. Sometimes patient is having some tingling and numbness with headache. So these are important questions. Another one, when did this headache begin? How did it start? It's gradually, suddenly, or some other way. So this is called onset of the headache and progression we should ask. Where is your pain? Where exactly in the head? Is it frontal side? Is it temporal side? Or is it on the back of the head? Important point. What kind of pain? If the patient can explain, it's nice. Otherwise, this is a bit difficult sometimes because patient may not know what exactly is the character of the pain, but nevertheless, we ask this. Do you have other medical problem or not? Remember, there are so many other causes of secondary headache. So if the patient is having those medical problem, who knows, that may be the cause of headache. Do you take any medicines or not? If so, what is the name of that medicine? We want to know the name. If patient is taking tetracycline, for example, okay, or vitamin A derivative, this may be simply a case of benign intracranial hypertension. Another question, have you recently hurt your head or had a medical or dental procedure or not, to find out about the head injury or some related problem. So these are the important history taking in a case of headache. Now, there are certain drugs which can cause headache. Okay, certain drug which can cause headache as a result of their side effect or adverse effect. Now see there, or they can also associated with intracranial hypertension, also known as pseudotumor cerebri. Use of antibiotics like tetracycline, minocycline, nalidixic acid, and trimethoprim sulfamethoxazole combination. What is another term for this combination?
Cotrimoxazole.
Very good.
Cotrim.
Very good. Okay. So I'm already getting the answer. I'm sure many other students know this. Cotrimoxazole. Okay. Cotrimoxazole is a combination of trimethoprim and sulfamethoxazole. So it is associated with intracranial hypertension, but not very commonly. So from the exam point of view, different types of tetracycline and nalidixic acid is also important one. Nalidixic acid is not a very commonly used antibiotic. Many of the students even have not heard the name probably. It is one of the drugs which is used for the treatment of urinary tract infection or UTI. Okay, UTI, nalidixic acid. Corticosteroid and drugs like isotretinoin, tamoxifen, and cimetidine are also associated with headache. They are also important drug for intracranial hypertension. Now, isotretinoin is vitamin A derivative. This is a drug which is used very commonly these days for the treatment of acne vulgaris. Isotretinoin, acne vulgaris, severe type of acne, isotretinoin can be used for the treatment. So one of the side effects may be headache. What is tamoxifen? Yes?
Tamoxifen is
anti-estrogen drug used in breast cancer.
breast cancer.
Anti-estrogen drug used in breast cancer.
Very good. Anti-estrogen, which is mainly used in the management of breast cancer. Excellent. Tamoxifen, anti-estrogen drug used in the treatment of breast cancer. It is associated with headache. And I don't want to ask this question. I'm sure 100% of the student knows. Cimetidine is H2 receptor blocker, which is used in the treatment of peptic ulcer disease. Cimetidine. Okay, so these are some of the important drug names for you. Now let us examine the patient who has come with headache. What are the important physical examination finding we may get in the patient? The primary purpose of the physical examination of headache patient, okay, is to identify the causes of secondary headache. There are so many causes of secondary headache, so we can identify some of the clues. The examination should target the area which are identified as abnormal during the headache history. We have already taken the headache history. So if you find some important point, your examination should be focused on those points only. Otherwise, you will be lost. Otherwise, it will take a long time to examine the patient. That's why headache history is such an important point. Now, the general physical examination should include vital sign, and one of the most important vital sign here is blood pressure. If blood pressure is high, we may get, we have found the cause of headache probably. That is the cause, raised blood pressure. Okay. Fundoscopic and cardiovascular assessment. See here, fundoscopic and cardiovascular assessment. Fundoscopy is absolutely necessary if a person is having headache. Who knows? The person may be having raised intracranial pressure, and as a result of this, there is papilledema. It is called papilledema. So if papilledema is there, we already covered this topic. If papilledema is there, it indirectly tells us there is raised intracranial pressure, and we need to find out the cause after that. Cardiovascular system examination is very, very important because, for example, if there is some left atrial disease, which is throwing a small emboli into the brain, that emboli may be causing ischemic problem in the brain. That is also associated with headache. So many different associations can be explained here. Okay, palpation of the head and face. See here, palpation of the head and face. There is one condition which is known as giant cell arteritis or temporal arteritis. See here, this temporal arteritis is associated with swelling and thickness of superficial temporal artery, which can be felt if we palpate exactly at the temple area of the skull. So this is one of the good example I can give here. Let's move on. A complete neurological examination is essential and the findings must be documented after you do the examination. You write what are the findings there. So see here, this is very important class, okay? You already gone through the neurological examination and so many other important topics. Now, I don't think it is very difficult for you to understand what is written here. The examination should include mental status. What is the mental status? What is the consciousness level in the patient? Cranial nerve testing should be done. All those 12 cranial nerve should be tested quickly. What is the pupillary response? Is the pupil constricting with light or not? What is the motor strength testing? This is called motor examination, test for the power. What about the deep tendon reflex? Are they exaggerated or absent or normal? What about the sensory nervous system? Is there presence of Babinski sign or not? If it is present, it shows there is upper motor neuron lesion. What about the cerebellar function? Is there dysdiadochokinesia present or not? What about the nystagmus? Can the person walk on a straight line or not? If the person cannot walk, we call that ataxia. What about the signs of meningeal irritation? Are they present or not? Okay, whenever you hear about meningeal irritation sign, always remember three things together: neck rigidity, Kernig sign, and Brudzinski sign. Neck rigidity, Kernig sign, and Brudzinski sign. We'll again talk about these in the topic of meningitis because it is very, very important there. Now, let me ask you one thing. If Kernig sign, Brudzinski sign, and neck rigidities are present, apart from meningitis, what other diagnosis comes in your mind?
Encephalitis,
Meningitis,
viral
meningitis,
Okay.
meningoencephalitis, meningitis, meningitis.
Okay, good, good. One more. I want one more answer there.
Subarachnoid hemorrhage.
Subarachnoid hemorrhage.
subarachnoid hemorrhage.
Very good.
Subarachnoid.
Now the answer is complete. Excellent. Okay, now I'm getting all the answers here. So the answers are meningitis, meningoencephalitis, ruptured brain abscess. Remember, brain abscess alone will not give rise to signs of meningeal irritation. But if it ruptures, then it will lead to meningitis secondarily, and now it is associated with meningeal irritation sign. Another condition is called meningismus. Meningismus. Now, meningismus means there are some local condition in the neck. Okay, meningismus. Don't forget this. Some local condition in the neck, or upper lobe pneumonia, or tonsillitis, or enlargement of the lymph node on the neck, which irritates the muscle there, and there will be spasm of the neck. Importantly, only neck rigidity is seen in meningismus, not Kernig and Brudzinski sign. But nevertheless, this can be mentioned here. And very important, another condition is SAH, subarachnoid hemorrhage. Favorite questions during the Viva exam. Now let's move on. Particular attention should be given to detecting problem related to the optic, oculomotor, trochlear, and abducens nerve. And these are the respective cranial nerve to third, fourth, and sixth nerve, because these are very commonly affected, okay, by different intracranial lesion. So examine them quite well. That's the point. Now let's proceed further. Let's talk about some of the important types of headache and some important physical finding along with it. If headache occurs along with fever and rigidity of the neck, without any doubt, the first diagnosis that should come in your mind is meningitis. It can be bacterial meningitis, viral meningitis, or tubercular meningitis, or even fungal meningitis. Okay, it depends on the history. Is it acute type of history or chronic type of history? Along with neck rigidity, other signs of meningeal irritations may be there. Now, headache without fever but only neck rigidity and other signs of meningeal irritation, it can be a case of subarachnoid hemorrhage. Just now we talked about it. And during this condition, the headache is the worst ever type of headache. If we ask this question, if the patient was constantly having headache before, patient can complain, doctor, I have never felt that type of headache in my life. This is the worst headache I have ever felt. Sometimes patient is unconscious. They cannot even give this history. And it is very typically mentioned in the book, this is the thunderclap or thunderbolt type of headache. This type of questions are very commonly asked in the MCQ exam. Thunderclap or thunderbolt type of headache. The diagnosis is subarachnoid hemorrhage. Okay, let's move on. Now let's talk about what are the important findings of raised intracranial pressure headache. Now you already gone through this topic before, so this is just a revision from the topic actually. In this condition, the headache is worse in the morning and improves throughout the day. Improves throughout the day. Probably it is worse in the morning, okay, because in the night time, because we are in the supine position, it all depends on the circulation of the CSF during that time. And when we move around during the daytime, probably the circulation of the CSF improve a little bit. That's why the headache is worse in the morning and improves through the day. It is associated with morning vomiting, like a projectile type of vomiting in the early morning. The headache is worse bending forward, and it is worse with coughing and straining, because there is a raised pressure when we do this type of things. It is relieved by analgesia. Different type of NSAID will cause relief of this headache, and headache is not very severe. It is a dull ache type of pain. It is not like subarachnoid hemorrhage. Okay, so this is called headache of raised intracranial pressure. Now let's move further. Whenever you take the history, and if the patient is giving history like this, I'm having deep dull type of headache which is disturbing the sleep, okay, and I'm also vomiting early in the morning, and the headache is severe in the morning time, probably this is a case of brain tumor. A case of brain tumor. Now there are different types of brain tumor. Different names are there. So let me quickly write these names because these are the important questions for you in the exam. Astrocytoma. Okay, astrocytoma. Glioblastoma multiforme. Glioblastoma multiforme. Oligodendroglioma. Oligodendroglioma, okay, and ependymoma. Ependymoma. See, these are some of the important types of headache. Okay, let me write it here so that you can clearly see it. Some others are also there, like medulloblastoma. Medulloblastoma. So these are common examples of brain tumor. So who knows, any one of them may be there and causing the headache like that. Now, headache which is induced by coughing, lifting or bending, and severe in the morning time and associated with projectile vomiting. It is again a type of brain tumor, but in this condition, the brain tumor is present in the posterior fossa near the fourth ventricle, and that brain tumor is compressing the fourth ventricle and doesn't allow the drainage of CSF. Means it doesn't allow the CSF to go into the subarachnoid space. If it doesn't go there, then there is a problem in drainage. This type of brain tumor is medulloblastoma. Posterior fossa brain tumor. Remember, medulloblastoma is the good example here. Now, one important example here for you. If the patient says they are having unilateral headache only on one side of the head, it is a pounding type, okay, pounding type of headache. They also have some visual change. They have claudication of the jaw. They are also having mild fever, weight loss, and scalp tenderness. This scalp tenderness is a very, very important clue. This may be a case of temporal arteritis or giant cell arteritis. This is a commonest type of vasculitis which is there in the patient. Now let me elaborate a little bit on here. Unilateral pounding type of headache. This visual change. Now can you tell me why is there visual change in this condition? Anyone? Anybody?
Sir, because of the dilation of superficial temporal artery, maybe it compresses the optic visual system, sir. So maybe there occur visual changes.
Okay. Any other student? Okay. Mujib has given his answer. Anybody else? Okay, this may be a little bit difficult questions for you, so let me explain this. Now remember,
maybe the
yes,
temporal
yes,
artery branches to the temporal artery branches to the eye ophthalmic branch. So because of
okay,
this, the vision may be blurred.
okay, Saddam. Now listen here. That is not the proper explanation here. Probably you have forgotten. We have already taken this class long time ago in pathology. Whenever you have temporal arteritis or giant cell arteritis, okay, there is a high chance of involvement of ophthalmic artery also. The same type of changes are developing inside the ophthalmic artery also. And ophthalmic artery is responsible for, okay, the blood supply of retina. That's why there is visual change. And one very, very important point, the person can become blind if the treatment of this condition is late. And prednisolone and corticosteroid is the treatment here. So we need to be quite clear about the diagnosis and start treating the patient early. Jaw claudication means whenever the person is eating, during that time there is movement of the jaw. The muscles of mastications will be active. The person will have pain during that time. This is claudication of the jaw. And this is also associated with decreased blood circulation there. The claudication term is the same as the intermittent claudication, which you already know, which occurs in the calf or the thigh area. When there is peripheral vascular disease, whenever the person runs or do some heavy exercise, there will be decreased blood flow now, and that lead to ischemic pain. We call that claudication. The same type of situation here also. Now, let's talk about something else. What are the features along with headache? If these features are present, that shows the causes are quite severe. In other words, these are like a warning sign of severe condition. So let's talk about them now. If the headache is very, very severe, it's the worst headache ever explained by the patient like that, we take it very seriously. And the obvious diagnosis is subarachnoid hemorrhage. First severe headache, never ignore it. Okay, do some good examination and investigation. If the headache is progressively worsened over days or weeks, take it seriously. Do not ignore it. Oh, it looks like a tension headache on you. So can you please take some NSAID and come back after 2 weeks? We don't say like that. We have already tried that before and the patient has not got better. So some proper investigation is necessary. If there are abnormal neurological examination finding, always take it seriously. Why the neurological examinations are abnormal? Because there is some pathology inside the brain. If the headache is induced by bending, lifting of the weight, or cough, it strongly shows there is raised intracranial pressure and there has to be some cause for that. Who knows? There may be a space occupying lesion inside the brain, or there may be some other diseases like some infection, some inflammation, something like that, or maybe pseudotumor cerebri. If the headache is there in the early morning, it shows brain tumor or again raised ICP, or may be caused by some space occupying lesion. Another important feature of severe underlying cause would be onset after the age of 50 or 55. Brain tumor can develop in the older age. Cerebrovascular accident very common in the older age. So these are some of the important points. So what I am saying here, okay, we should take a very good history, do a good physical examination, especially neurological examination, followed by cardiovascular and other related system if you think they are necessary to examine. Otherwise, it will be a wastage of time, and proper investigation, whatever you think are necessary. Do not ignore the patient. Do not say your headache it doesn't look that serious, so can you come after a few days or few weeks? We don't say those if these features are present. Now, after knowing those important history and those danger signs which are associated with severe pathology, let's talk about the three most important types of primary headache and how we diagnose them. Let's start with diagnostic criteria for migraine. Migraine is very common in general population, and migraine is diagnosed by this diagnostic criteria. Remember, all three types of headache are diagnosed by this diagnostic criteria. You don't need any investigation for the diagnosis of this type of headache. That's why these are important for us to know. The migraine is roughly divided into two types: migraine without aura and migraine with aura. Now, we all know aura means some warning sign and symptom before the headache starts. Different patient complain different type of aura. Sometimes they just complain of flashes of light in front of the eye. Sometimes they complain a dark curtain in front of the eye. Sometimes they hear some abnormal noise inside the ear, which is called tinnitus. So something like that. So let's talk about them. So migraine without aura. So we need at least 5 attacks, okay, of the headache fulfilling criteria B through D. So for the diagnosis, at least 5 attacks should be there already in the patient. Along with them, the duration of headache is important. So see here, headache lasting from 4 to 72 hours is the duration, and it is untreated or unsuccessfully treated. Patient had taken some medicine. Everybody takes. Whenever we have headache, we take like NSAID, paracetamol or ibuprofen or something like that. It did not get better. And it lasts up to 3 days. 72 hours means 3 days. A patient may complain of headache for 3 continuous days in case of migraine, or it may last few hours like 4 to 6. Now we need at least 2 of the following pain characteristics point here. At least, okay, these 2 of the following pain characteristic features would be there. Out of these 4, at least 2 we need for the diagnosis, and these are unilateral location means headache on one side of the head only. It's a pulsatile in nature or pulsating character. It is moderate or severe in intensity, means how severe is the pain in the scale of 1 to 10. It is usually more than 5. And the last one, it is aggravated by walking upstairs or doing similar type of physical activity. So we need at least 2 of the following 4 pain criteria. And lastly, during headache, at least one of the following features should be there in the patient. And these are presence of nausea or vomiting, presence of nausea or vomiting, or presence of photophobia and phonophobia. Photophobia means it's a problem in vision. Phonophobia means problem in hearing. Means there is a irritation when a bright light comes in front of the eye, or in the bright sunshine the person feels irritable to see. This is called photophobia. And phonophobia, the person doesn't want to hear loud music or loud sound during that time. That is called phonophobia. So let me explain once again, because this is a little bit confusing for the student. So let me make it easier for you. Whenever we take the history, if the patient says, doctor, I already have more than 5 attacks, okay, of headache, you got 1 point for that. And ask about the duration of the headache. If the patient say it is between 4 to 72 hours, you get another point. At least 2 of the characteristic point from the pain should be there. Any 2 out of these 4, and any one of these 2. Okay, any one of these 2, either photophobia or phonophobia or nausea and vomiting. So if we all are there, then without any doubt, this is a case of migraine. You don't need any investigation for the confirmation. But whenever your examiner asks like this, you really don't want to do any investigation? Are you sure? Examiner is giving you clue. You can answer very intelligently here. To rule out other differential diagnosis of headache, to rule out other secondary causes of headache, I can do certain investigation, but to confirm the migraine itself, I don't need any other test. Now, the typical triggers for these headaches are alcohol or drinking, okay, consumption of chocolate or eating chocolates, cheese, monosodium glutamate. This is very commonly used, okay, in the food. It makes the taste better in the food, but it is not good for the headache patient. Hunger or irregular sleep pattern, these are the typical trigger in a migraine patient. So as a doctor, it is my duty or my job to tell the patient about these typical triggering points. Do not drink alcohol, do not eat excessive chocolate or cheese, or Ajinomoto is another name for monosodium glutamate. Ajinomoto, okay, is the another name. Do not stay hungry for a long time, and sleep adequately, at least 8 hours during the night. So if the patient does that, then probably the attacks of the migraine will not come earlier. Now, what are the treatment? What are the treatment options? Very important part. See here, there are 2 types of treatment available in migraine. This is treatment of the acute episode, means right now when the patient is having headache, we treat this episode, and future episodes, okay, the upcoming future episodes also needs to be treated. That's why we discuss like this: acute episode treatment and prophylactic treatment. So NSAID and opioids are the important drug which we use all the time in the acute episode treatment, like NSAID, paracetamol, ibuprofen, diclofenac, okay, naproxen, and all those different type of drugs can be used. They can be tried. If they do not relieve the pain, you can go for opioids like codeine. Okay, codeine is very commonly used drug as an oral one. Sumatriptan is another important drug which is very commonly used all over the world for the management of migraine. Sumatriptan, this is serotonin receptor agonist, and it can be given per oral, intranasal, or even subcutaneously. So different formulations are there. Ergotamine is another drug which can be given, and dopamine antagonist like metoclopramide can also be tried. This is also known as anti-emetic agent. Whenever a person is having vomiting, we can try this drug for the stoppage of vomiting. So the in migraine also, remember, there is a high chance or tendency of vomiting. So this drug may help. Regarding the future episodes, we use prophylactic drug, and these are propranolol, important type of beta blocker, and timolol belongs to same family, sodium valproate or valproic acid, okay, and even amitriptyline. Okay, let me write that drug here. Amitriptyline is also commonly used. Now, amitriptyline is what type of medicine? You can answer me that.
Tricyclic antidepressant.
Very good.
Tricyclic depressant.
Very good. Okay, it is TCA, tricyclic antidepressant. This is an important drug in the management of depression, but in this condition we are not using it for depression. Please remember this. This drug has some effect in the prophylactic purpose of migraine, and it should be given for a longer time. See that, for 3 to 6 months at least, and sometimes even longer than that. Let's move further. Now, after discussing these migraine headache, the other two types of headaches are left, which are tension type and a cluster type. So what are the diagnostic criteria for episodic tension type of headache? This is the commonest headache among those three. Tension type headache is very, very common. So these are the diagnostic criteria. At least 10 previous headache episode which fulfill criteria B through D, and the number of days with such headache are less than 180 days per year. So in 1 year there are 365 days, we all know that. So the headache, number of days with such headache should be less than 180 days. So less than 6 months, okay, headache should be there. This is one of the criteria here, remember this. And already the patient should be having 10 previous headache episode. This is just one criteria, okay. Now other criteria should be fulfilled, and they are headache lasting from 30 minutes to 7 days, very long duration. Some patient may complain of headache for so many days, 3, 4, 5 days, up to 7 days as well. At least 2 of the following pain characteristic points should be there, like pressing or tightening quality. Pressing or tightening quality, and this tightening or pressing quality is all around the head. This is in bilateral location, not only on one side. So it is a tight type of ring which is compressing the head everywhere. This is the typical explanation given by the patient who are having tension type of headache. The intensity is mild or moderate, okay, less severe than migraine, and there is no aggravation by walking upstairs or similar routine type of physical activity. There is no aggravation. So patient may be doing their job. If they are a student, they may be going to the classes and those type of things. There is no real aggravation by doing those. But remember, in migraine they will be aggravated. And both of the following are necessary from the D now. See here, there is no nausea or vomiting, but anorexia may occur, which is not a very important point. And photophobia and phonophobia are absent, or one is present but not the other. So these are important diagnostic criteria for tension headache. So see that, number one, 10 previous headache episodes should be there. Number two, the headache should last for more than 30 minutes up to 7 days. From the pain criteria, we need at least 2 out of these 4, at least 2. And from the D option, we need both of the following. The patient should not have any nausea or vomiting, and there should not be any photophobia or phonophobia. So if these are present, then we call it tension headache. What is the treatment then? What type of treatments is available or we give to the patient? Relaxation. This is probably one of the most important point here. Relaxation. We all can have tension headache in different parts of our life. Okay, we are so busy a person, isn't it? For example, if I take example of medical student, they have so many classes throughout the day. Okay, they have a lot of assignment and something like that. Now, if you cannot manage your time, you will be stressed and you may have headache. This type of headache is called tension headache. So it is very, very common, not only in the medical student. I'm just taking one example there, okay? It can happen to anyone. So whenever you have that type of headache, just try to relax. And that relaxation can be done by different way. It depends on the individual. Sometimes music, sometimes taking shower, sometimes just going outside in a fresh air, sometimes just drinking tea or coffee. Okay, so these all are different relaxation. But sometimes what people say, oh, I am too much stressed, I'm having headache, so smoking will decrease my headache. This is just an excuse. Smoking will never decrease headache. So this is the excuse from the people. So don't do those type of things. Do those type of relaxation habit or exercise which are good for the body. Apart from them, drugs are also essential, like acetaminophen or paracetamol or NSAID. These are enough for the relief of headache in case of tension headache. And if there is a bit of tightening of the muscles for a longer time, you can use muscle relaxant. Benzodiazepines are an important muscle relaxant in this regard. Now the last part is cluster headache. It's a very severe type of headache, but easy to diagnose. So let's go and talk about the diagnostic criteria here. So all of you, please pay attention. At least 5 attacks fulfilling the criteria B through D. See there, B, C, D, okay? At least 5 attacks should occur whenever the patient has come to me. When I take the history, they should provide me this point. Doctor, I already have multiple episodes in the past. And if these fulfill the following criteria, then the diagnosis will be quite easier. Severe unilateral, orbital, supraorbital, or temporal pain, which may last 15 to 180 minutes in the untreated case. The 180 minutes is, okay, how many hours? 180 minutes, 3 hours, isn't it? 60 minutes is 1 hour, 183 hours. So from 15 minutes to 3 hours, the pain may be there in an untreated case. It is usually unilateral pain, and it is usually present on the back of the eye or around the eye, or sometimes even on the temple area of the head. Headache is associated with at least one of the following sign on the pain side. Out of these 8, okay, if only one sign is present, it is highly suggestive of cluster headache. Now let's go through them. Conjunctival injection. Now, conjunctival injection is also known as conjunctival congestion, a red eye. Okay, red eye. But this is not because of infection or inflammation there. Lacrimation, excessive tear flow. Lacrimation. Nasal congestion, very important point. Okay, the person feel the nose is stuffy, there is blockage of the nose. Rhinorrhea, nasal discharge, serous type of discharge. Forehead and facial sweating. Meiosis, What is meiosis?
Constriction of the
Constriction of pupil.
Very good. Constriction of the pupil. So it is very easy for us to examine that. Just throw the light, okay? But remember, you need to see very quickly because of the effect of the light. The pupil will also constrict. Ptosis is a drooping of the upper eyelid. Every student know, I'm sure about it. Ptosis. And edema of the eyelid, especially the upper eyelid, more common than the lower. So any one of the following sign on the pain side is highly suggestive of cluster headache. So very easier diagnosis. And lastly, the frequency of attack is 1 attack every other day to 8 attacks per day. So the life of this patient is really suffering. This is a severe type of headache, and if that patient is having 8 attacks per day, it's very, very difficult, okay, regarding the quality of life. So this is cluster headache. Now, what is the management? Now, see here, you can see so many different type of treatment options here, like prednisolone, lithium, ergotamine, methotrexate, verapamil, and 100% oxygen, and sumatriptan during the acute episode. Now, a common question should come in your mind: which is the most effective drug in the treatment of this cluster type of headache? And the answer is, okay, answer is 100% oxygen. So see here, let me underline this for you. This 100% oxygen is the most effective therapy of a cluster headache. Never forget this. This is a very important question which will be asked to you. So what does that mean? Whenever a patient comes to us with this type of headache and we confirm it by history taking and this diagnostic criteria, we give high flow oxygen, 100% pure oxygen, and high flow like 4 to 6 liter per minute, and patient will be free of headache after 15 to 30 minutes. Patient will be fine. So this is a very effective therapy. All other drugs can also be tried, like prednisolone. It's a type of corticosteroid. Lithium. So lithium is used in which other condition?
Bipolar.
Bipolar disorder. Bipolar disorder.
Very good. Bipolar disorder. Excellent. Bipolar disorder. One of the important drug is lithium. Ergotamine is called ergot alkaloids. Okay, ergot alkaloids. This is a vasoconstrictor substance. Methotrexate. Okay, methotrexate is not commonly used at all, but one of the important question which is associated with methotrexate in the exam: if this drug is used, okay, patient may develop fibrosis in different parts of the body. Fibrosis. This fibrosis may be developed in the retroperitoneal area, retroperitoneal area, as well as in other part of the body. So try to remember this. Can be asked as an MCQ question in the exam. Verapamil. This verapamil, everybody know, is anti-arrhythmic drug or calcium channel blocker, you can say, verapamil. Okay, so these are very important drug which are asked in the exam, but among them the most important is 100% oxygen flow at a good amount, 4 to 6 liter per minute, and within 15 to 30 minutes the patient will be fine.